Imagine that just 700 miles off the coast of Florida, there's a country there that has the highest HIV/AIDS prevalence in the world outside of sub-Saharan Africa. That country's Haiti. Imagine now working in a rural clinic there, and you literally are losing count of how many children that you've seen die that month from HIV/AIDS. Some of these children that you know, you've literally lost count. Imagine praying for your friend as his son is dying, and during that, you can see your friend washing his son's body with his own tears, watching him take his last breath, knowing there's nothing you could do to save him. That was my life when I started my journey with trying to end pediatric HIV/AIDS in this generation. Although HIV/AIDS was an immediate death sentence for thousands of children in Haiti in the mid-2000s, the country did not have a way to test or treat them. Living in Haiti with my family in a rural village and running a clinic, we honestly saw way too many children die unnecessarily from this. We could treat a host of deadly diseases, malaria, pneumonia, but the one thing we could not treat was HIV/AIDS. I want to give you a little bit of background real quickly on this. When a baby's born to an HIV-positive mom, we have to first test them. It's very important that we test them within 6 weeks of age. And then if they're positive, get them on HIV therapy. The good news in that, if we do get them on therapy, which is life-saving HIV medication, we decrease their chance of dying by 75%. That is huge. However, there's a challenge. There's actually a problem, is that the testing is very hard. It's complex. It's not the same kind of testing that we do as adults. It's different. It's called HIV DNA polymerase chain reaction testing. It's as complex as it is to say. HIV DNA PCR. And what's even crazy is that once you take the blood for this, you actually have to send it to an even more complex laboratory. And in resource-limited countries, especially back then in Haiti, this is a huge challenge. But now on the contrary, in the United States, that testing, it's readily available. So if an HIV-positive mom who's pregnant goes into a hospital, delivers in the United States, that testing is actually offered to that child the same day they're born. And if they're positive, they're actually able to initiate that therapy. And so I started thinking to myself, why is it that we have this availability in America, but we don't have it in Haiti, where we exponentially needed it so much more? So while living there, I started to try to figure out which Haitian government officials were over HIV programs there. And I found out that they were actually partnering with the U.S. government. So I started going to the Capitol. I started meeting with these officials. I started encouraging them. In the end, I actually even started begging them to please bring this service to Haiti for these children. It was desperately needed. Their answer was always, we'll get it there in 2 years. In 2 years, it'll come. Finally frustrated, I asked them, if this was your child, would you be okay with your own answer? And nothing changed. Nothing changed at all. The narrative had been sent. It really just wasn't that important. They would get to it when they could. So I got to thinking, what if we actually could do this? What if we could do this on our own? And so during that time, I actually got tired of waiting on them. And so what we did with partners and partnering with a hospital in northern Haiti, with Johns Hopkins School of Medicine, Johns Hopkins School of Public Health, and of all things, the Kenyan government, over 8,000 miles away, we eventually partnered with them too. Two friends and I, we designed a pilot program with that hospital in Haiti, and we set off for our endeavor. Now, in doing this, it was a very tough endeavor. And I can remember thinking back during this time when we were trying to design this program of how we did it, getting an actual HIV test from Haiti all the way to Johns Hopkins. And I think about it and it's mind-blowing. But I also think about, sadly, about all the whispers of doubt that it couldn't happen. Whispers from colleagues, whispers from the academic elite that it just couldn't happen. And the reason they would say it was because it was in Haiti. Well, the good news is that it did work. Not only did it worked exceptionally well. And we were so thankful for that. So within months, actually, this program, it started to become the national program. It started to grow all the way across the country. Now, we still didn't have a way to test in country for this, so we were sending our samples all the way from Haiti to Baltimore. And actually, it was running pretty smoothly. So on a Monday morning one time, I was there in Baltimore, and I went into the HIV lab there at Hopkins, and I spoke to the director to see how our samples were for that week. I could tell he was kind of down. So I asked him, I said, man, what's going on? And he said, Brad, we're testing more children in Haiti in 1 month for you guys than we are for the entire United States in 1 year. We can no longer do this. We just don't have the resources. And he says, we have to stop. And I said, guys, we can't stop this. We're not that kind of organization. We're not those kind of people that go in and partner with another country and then we pull out. He said, I'm sorry, you have 2 weeks. You have 2 weeks to find another lab and then we're done. So that afternoon on Monday, I started calling other universities in the United States, asking them, can you please take over this program and test for us? And they all said no. Tuesday, I woke up, I met with my friend who had lived in Kenya for 15 so years and was telling him about my problem. And he said, Brad, I know a Kenyan doctor I've been friends with for a long time. He actually works for their government in the HIV program. And he goes, you should email him. So that night I did email him. And I'm thinking, maybe he'll get back to me in 1 week, 2 weeks, or even at all. He doesn't even know me. Well, to my surprise, that next morning on Wednesday, I got an email from him. And it said, Brad, if you can get here to talk to me, I'll listen. So that next day, Thursday night, one of my friends and I, we jumped on a plane. We flew to Nairobi, landed there Friday night. And on Saturday night, there in Nairobi, Kenya, we were having dinner with our new friend. And he said, after listening to us, his heart was touched. And he said, Brad, if you can get those samples from Haiti here to Nairobi, he goes, we'll test them for you. So that's what we did. And within 6 months, 95% of all babies being tested for HIV in Haiti were being tested 8,000 miles away in Nairobi, Kenya. It was a beautiful thing. Africans helping Haitians. It was amazing. So now we have this program. It's starting to grow. And eventually, we obviously want to make it sustainable, right? So we were able to validate a CDC lab in Haiti so they could test their own children. So we started putting our sights on Kenya, where the epidemic is really bad. It was so much worse. Even though Haiti was rough, Kenya was even rougher. But what we started noticing is that our program was growing. And in Kenya, the volume was exponentially more. And so when you have 100, 200, 300, 400 children in your program, it's easy somewhat to manage. But when that grows to 1,000, to 10,000, you start noticing little fragments. It starts breaking up, and it becomes much more difficult. The narrative starts to change. Even though we had changed the narrative before, now the narrative is starting to change that. It's becoming mediocrity, and that's never a good thing. So a quick background real quickly again on HIV/AIDS. We have an HIV-positive mother. She gives birth. We know we have to test that baby, right? And we know if they're positive, we get them on therapy. And if we get them on therapy, most likely they're going to live. But let's really look and see what this looks like, this program looks like. It looks like amazing mothers who are doing everything they can while they're in an overcrowded room, desperately waiting to see if they can get their child tested. It looks like a moto taxi who literally has 100 of these samples, maybe even more, going through the cities like Nairobi, or even yet going a full day from rural villages back into the capital with these samples. It looks like a very understaffed and a very underpaid laboratory that receive hundreds, if not 1,000 of samples each day waiting to be processed. It looks like a regular storage room, and this is a good one. When babies come in, that the nurses are trying to find their chart, a lot of times giving up, and the parents having to start all over with the history of their baby. It looks like resilient and strong mothers who, a lot of them make less than $1 a day, who are coming back to the clinic, trying to find resources to do that, coming back to the clinic over and over and over to get their child's test result. A lot of times that test result never coming. Thus, they're giving up on the system, and a lot of times their child passes. And finally, man, it's compassionate. It's brilliant, amazing nurses, amazing healthcare workers that are doing the best they can within the system that they have. In reality, these programs take a lot of steps. There are a lot of steps within it. And if just one of those steps fail, the entire program fails, which means we then fail the mother and the child. And as systems were growing, as these programs were getting bigger, that's exactly what was happening, is that, again, the narrative was becoming mediocrity. And that's never a good thing when we're talking about life. So one of the problems, one of the biggest challenges is to get the care that these children and these moms needed. We just weren't able to do it because, one, it was a very passive system. It was actually the stakeholders, the mothers and children pairs, the doctors, the hospitals, the labs, none of them were communicating with each other. So really what it was a passive and a blind system that wasn't working. So thinking of the technology that they actually have, how can we take a system that functions like this with no one speaking to each other, with life-saving interventions on the line, to a system that functions like this? During that time, mobile technology was booming in East Africa. In Nairobi alone, 90% of all adult women had access to cell phones. We're not talking smartphones. We're talking phones that can send calls, that can make calls, that can receive calls, that can send and receive text. That's it. So thinking, how can we harness that technology to be able to help these mothers and babies? I started thinking, when we first started sending samples, we were from Haiti to Baltimore, to Johns Hopkins, from Baltimore to Africa. We were using UPS, DHL, FedEx, and I thought, if they can send a package of these children's blood samples through that course and know each single place that package made it, or even more importantly, that it didn't make it, how come we can't do that in caring for children with HIV? It's insane. We have to change the narrative. So that's what we did. Using this existing technology there in Kenya, we designed a program that used very innovative algorithms that would actually tell the stakeholders when an actual intervention, a step happened in the care to help them live. But more importantly, it told them when that step didn't happen. For example, if a lab never showed up, it would tell the lab that it didn't show up. If a mother hadn't received the results, it was now in real time. It would tell her, you don't have to come back over and over and over. You just come back one time, keep your resources, and save them for your family. Man, and just as importantly, and as importantly, it meant that children who in the past had fallen through the gaps that were HIV positive, they weren't going to fall through the gaps anymore. They were going to live. This system was called the HIV Infant Tracking System. And it was a game changer. As you can imagine, our team, Kenyans, some Tanzanians now, Malawans, Americans, we're all excited. We know that this is going to take off. So because we're starting to work in Kenya now, we set up a meeting with the Kenyan government, specifically the HIV Working Technical Group. We get ready to present to them, and we know that we have something that can save lives. They're going to be all over it. Oh, man. We were met with brutal resistance. The same sort of resistance that happened to us when we were in Haiti a few years ago. The bureaucracy's answers to what we brought were no. So during these meetings that we would have with the government, I would write down the answers that they would say why they didn't want it or they didn't think it was needed. Of course, there was no. No thanks. This can't be done. I know people and they will never use this. It is too expensive to build. We don't need this. This will fail. HIV nurses and doctors will never use this. And the one that just drove me insane, that gave me so much inspiration with my brothers, with my friends, with my sisters, bring this together. It's too technical for the people in Africa. No way, man. So many times the Kenyans and Tanzanians, most of the time they're ahead of me in this. So we've been down this road before, and when you know what? we knew we had to be persistent, and persistence actually won out. The Kenyan government, after continuing knocking on their door, somewhat begging but demanding, they gave us permission to start and pilot our system in 2 hospitals in the country. And we did. They gave us 1 year to look at outcomes, and you know what? The outcomes were amazing. Some of them actually were groundbreaking. The narrative had been changed again. I can remember right after that, we were in this hospital. It's a small hospital in the South Rift Valley. It was a brutally hot day. We're all cramped in these exam rooms, and we're working with these mothers and fathers to listen to them and find out how we can change the HIT system to improve it to care for their children, even to care for their moms. And about midway through the day, there's this big knock on the exam room door. I get up and answer it, and in walks this very strong Kenyan man, very well dressed. Honestly, his appearance alone demanded respect. You could tell he was tired, and ended up, his name was Ajuk, Dr. Ajuk. He was a Kenyan physician from the coast of Mombasa, and he was a minister of health. And I so wish that I could replicate his thunderous voice when he asked me this. I said, "Hello, how are you?" And he said, "Good." And he just looked at me and he said, "What is this beast called the HIT system? We have heard about it on the coast, and we want it in our hospitals for our children." Man, Ajuk and I became good friends pretty quickly. And he stayed with us the rest of that week, and we eventually did move the HIT system out to his hospitals out on the coast in Mombasa and Malindi. So, thinking about that, about what we've done with them, and about all the things we've done with them, is I think of the outcomes that we've been able to have, and even publishing those outcomes in prestigious journals. But it wasn't until this moment with Ajuk that it really hit me that we have something special. And when I say we, I mean us, the Tanzanians, the Kenyans, the Americans, all of us together. We have something special, and the reason it was special is because finally the people were asking for it. They were not only asking for it, the people, they were demanding it. And it was amazing. So those 2 hospitals and 300 HIV positive moms and babies in Kenya actually ended up growing to 120,000 HIV positive mothers and babies in 4 countries. And our hope is that it spreads across the continent. But our big hope in all of this, again, Americans, Kenyans, Tanzanians, Malawians, Nigerians, is that we work ourselves out of a job. We want to work ourselves out of a job in ending pediatric HIV/AIDS, meaning the epidemic will be over. A mere desire and will to change the narrative, thus providing innovative solutions to solve dire problems. Man, I often ask myself, what if I would have been okay with the status quo? What if we as a team would have been okay when the government was telling us, no, we'll get this program here in 2 years, don't worry about it? What if we as a team and Kenyans didn't stand strong together and we didn't accept, we refused to accept those no's of the bureaucracies? Man, my what if in life is to end pediatric HIV in this generation. What will your what if be in life? Thank you.